All right, our next topic is HIV, human immunodeficiency virus. This is an RNA retrovirus. This is a sexually transmitted disease. Let's look at our case. A 22-year-old multigravida is a former IV drug user. There is a risk factor for HIV. Drug user, IV drug user. She was diagnosed HIV positive 12 months ago during her previous pregnancy. She underwent vaginal delivery of an infant who is also HIV positive. If we have a woman who is pregnant, HIV positive, who undergoes vaginal delivery, and who has not had any antiviral prophylaxis, the likelihood of the newborn being infected is 30%. And in fact, she had a baby HIV positive. She's now pregnant again at 15 weeks gestation. What are we going to do? This is from the World Health Organization and looks at the gathering storm. These are the number of cases of AIDS around the world. And you can see that the predominance is in sub-Saharan Africa and in South and Southeast Asia. Here's North America, much less. But sub-Saharan Africa, in some of these African countries, 30 to 40% of pregnant women are HIV positive. 30 to 40%. And the transmission rate to their babies is very high. I suspect that the next big wave is going to come from China. For many years, the Chinese government denied that there ever was a problem. Big time problems. In India currently, the Bill and Melinda Gates Foundation is giving $100 million. And it's not for treatment of HIV, it is for prevention of HIV. This figure looks at the increase in lifespan in African countries from 1955 to 1985, and you can see the lifespan was going up until about 1985 to 90, and it started going back down. Why did it start go back down? Because that latent period of HIV was now nearing its fruition, and those who were HIV positive started dying. What age group were these? Were these old people or young people? Young people in the prime of their life, dying. Notice how the lifespan went down. Now, interestingly, Uganda, it started to come back up. Why? Because in Uganda, they publicly made a crusade to educate the people about what is the mode of transmission, sexual transmission. In many countries, South Africa, for instance, Prime Minister Mbeki, for years, denied that HIV was a sexually transmitted disease. Only recently. The Prime Minister of Uganda appeared at the World AIDS Conference in Bangkok and said what they have done is to teach ABCs. A, if you're not married, be abstinent. 2, if you are married, be faithful. 3, if you can't be abstinent, and if you can't be faithful, at least use condoms. And in fact, it has worked. And I think we've got a major challenge ahead of us in prevention of AIDS. This was interesting. A Ugandan member of parliament has pledged to reward girls for their chastity by paying their university fees if they are virgins when they leave school. My goodness, how about the boys paying them? What is so tragic in some African countries, it is the folk belief that if a man is HIV positive and if he has sex with a teenage girl who is HIV negative, that he'll be cured. And when you look at the differential infection rate in adolescent girls and in adolescent boys, girls are far outweighed, far represented because of that. All right, I'm going to let the internal medicine people talk to you about the specifics of HIV infection, but I do want to talk about it in terms of pregnancy. Initially, you have a rising viral load. The CD4 count drops down. As the immune system takes over, it drives the viral load down, and the CD4 count rises. The viral load stays low for many, many years, on the average about 10 years. But gradually but surely, the CD4 count starts falling. When the CD4 count reaches about 250, the viral load will start rising. And as it rises, we start to get constitutional symptoms, opportunistic diseases, and death. Patients with HIV don't die from HIV. They die because of opportunistic diseases. The mode of HIV transmission is body fluids, similar to CMV, blood, urine, saliva, genital fluids. How is it transmitted? IV drug use, sexual transmission, perinatal. I'm going to focus on the perinatal transmission here. Residual effect, lifelong immunity or lifelong latency. And tragically, this is lifelong latency. Once you've got it, you're stuck with it. And the likelihood of survival has not been good. With the antivirals now, things are looking better, but many of these drugs have significant side effects too. The result of HIV immunosuppression is AIDS. The cause of death with HIV/AIDS is opportunistic diseases, tuberculosis, pneumocystis, toxoplasmosis, cytomegalovirus. If you're immunosuppressed, you can get systemic recurrence of CMV, and coccidiomycosis pneumonia can also become systemic. In terms of perinatal transmission, vertical transmission, it used to be thought that this was transmitted to the fetus transplacentally. And if it's transmitted across the placenta, then it really doesn't make any difference whether it's a vaginal delivery or whether it's a cesarean delivery. The studies, however, showed that when you had twins, there was a difference in the transmission rate between the twins. Now, if it was transplacental, should there be any difference? No, they should both be infected the same. But what was found was the lower twin had a higher rate of transmission than the twin that was presenting second. And it became clear that it was exposure to genital secretions that raised the likelihood of transmission. So vaginal delivery is clearly the highest risk in terms of transmission to the baby. Transplacental, less likely. Breastfeeding can occur, but it is much, much lower. And in many countries in developing countries, where there is poor nutrition, is the risk of dying from malnutrition higher than the risk of getting HIV from breastfeeding? And that becomes a public health issue. This is a chest X-ray. And if you look at this, are you happy with this chest X-ray? This is actually my chest X-ray in 1992. I live in Southern California, and I had got a little bit of a rash, I got a little low-grade fever, a little bit of pleuritic chest pain, and I wondered, what's going on? I talked to an infectious diseases friend, and he said, oh, you probably have Coxsackie, not to worry. So I didn't worry. I went home, however, and even though it was 105 degrees outside, I was feeling cold. I put on a coat, took my temperature, and I had a fever. I went back, saw a real doctor this time, took a chest X-ray, and what does this look like to you? It was read as atypical pneumonia. What's the most common cause of atypical pneumonia? Mycoplasma. How do you treat mycoplasma? Erythromycin. So I took erythromycin. Like a good patient. Hard on the gut. Did I get better? I didn't get better. Finally, I couldn't sleep laying on my back. 3 weeks later, this was my x-ray. Better or worse? Worse. Now, usually I like to go home. I don't like to stay in the hospital, but I told my wife, honey, you better take me to the hospital. I'm not doing well. My PO2 on room air was 60. Immediate bronchoscopy. Took washings and put me on IV erythromycin. Didn't get better. Spiking fevers, sweats. One day the resident came in and said, we want to get one more test on you. I said, what test is that? We want to get an HIV test. HIV? Me? HIV? And as I thought about it, why shouldn't I have HIV? Obstetrician, catching babies before they fall on the floor without gloves, cutting the umbilical cord, blood squirting all over the place. I've been exposed for years. The next 48 hours were the longest 48 hours in my life. Will my wife become a widow? Will I leave the hospital alive? That was a hard time. Well, I want to tell you, I did not have HIV. But what I did have was coccidioidomycosis pneumonia. They thought I had pneumocystis. Thank you very much. I'm doing just fine right now. This looks at the root of HIV exposure and what is the likelihood of transmission. If you are transfused with HIV-positive blood, 95% infection rate. That's pretty high. Now, what is the next highest risk? And it is mother to infant, 30% transmission if no antivirals and if vaginal delivery. And that's why perinatal transmission is so important to avoid. The current management, it is recommended that all patients be tested for HIV who are pregnant, and the recommendation is to have them sign an informed refusal rather than an informed consent. And the reason is because of the high rate of transmission to the baby. Vertical transmission rate without AZT, 30%, if AZT, less than 10%. So, we certainly want to give antivirals to the mother. Multi-drug therapy. The current recommendations by the CDC is that all women who are HIV positive should be given triple therapy, not just AZT, because they're concerned about the development of AZT resistance, particularly if they have a low CD4 count and a rising or high RNA load. So, regardless of the titer, we will start all patients with triple therapy at 14 weeks gestation. The delivery route, a cesarean is offered, particularly if the plasma viral load is over 1,000. If she has an undetectable viral load, is there any benefit to the fetus? There probably is not, and I suspect in the next few years we'll be coming out with guidelines for this. What will be the neonatal HIV test if the mother is HIV positive? And you know the baby's going to be positive because of passive maternal IgG antibodies which cross the placenta. This is an article from Lancet. A surrogate was breastfeeding a baby. The baby got HIV from breastfeeding. So, breastfeeding is a risk factor for transmission. This is some hopeful studies showing that gel placed intravaginally may prevent AIDS, and in many countries of the world, women are in a very precarious situation. Man demands sex, he's HIV positive, what can she do to protect herself? And this may be a possibility to help that. Everybody in the United States is recommended to get HIV testing, even the priest and even young people. That's the end of HIV, perinatal infections.